Good afternoon. Thank you, Mr. Chairman. I would like to start by say how pleased I am, and thank you to the organizing committee for inviting me here. And thank you to all of you for staying. I know it's nice outside, and I think Singapore is amazing. It's my second time here. I arrived last night, and today I've been asked to talk about controversies and confusion, so I think I'm the best speaker given the time difference, to talk about that. When I was preparing for my talk, I wasn't not sure whether to really mention items related to the definition of sepsis, but having been here for this afternoon session, I'm really pleased actually that I have those few slides that will not go into the details of the definitions, but possibly will set the scene for talking to you about the content of my presentation. As you heard, we now have definition number 3, and we've been spending all afternoon talking about concepts related to individualized care. We heard Professor Gordon early this morning, and then we talked several times about patients being different. And I must say that in reality, sepsis too has the credit of having moved forward from a static condition to the idea that sepsis is a syndrome where every single individual is at a different stage. It's also a credit of sepsis too to talk about the fact that patients have different predisposing factors, inflammation, infections, they have a different response and organ failure. So it's something that has been really going on for almost 20 years. The problem with that is once we apply this very complicated concept to big trial, we get into trouble. And I think probably this sentence summarizes the reason why we go into trouble. It's really, really difficult to understand the magical moment where something happens and you can treat it for everyone we include in a big trial. The other problem with sepsis too is that they use a very long list of source criteria. They are all pertinent, all important, but they increase confusion. And we did this survey 3 years after the guideline, the definition was out, and colleagues, doctors in different specialty could not speak the same language, and they were not able to understand what sepsis was. Even worse, 7 years after the definition was out, public had no idea of the concept of sepsis. And we're realizing nowadays how important it is to have public engagement to improve research and to improve outcome for several conditions. And this applies to sepsis too. Therefore, I think when we move to sepsis 3, we don't have the benefit of individualized care, even if now we have more tools to talk about individualized care, but we have a tool to have simple communication skills, simple way to talk about sepsis as an easy concept, and therefore maybe allow early intervention for treating the patients. What about the treatment? I think we've been talking about inotropes and fluids and lots of interesting new drugs, but if I have to summarize my way and my understanding of sepsis treatment at the moment, I think we're still going to talk about source control, antibiotics, and any of your favorite wonder drug to be used at the right time, of course. Well, after all afternoon talking about sepsis, we have not mentioned any single study, and we have not discussed at any time about interventional radiology. In the old days, we were inviting surgeons to our septic meeting because we knew the importance of, for instance, laparotomies. We're now learning that these are sometimes harmful, and still we have not engaged into the discussion, for instance, with interventional radiology. We don't know how much having a good collaboration and early source control through different way can improve the outcome of our patients. Similarly, interesting discussion can be done about antibiotics. We are all becoming champions of giving drugs within the first hour. Nice guidelines came out in England, and over the last 6 months, the ability of giving antibiotic within the first hour is increased from 40% to 80%. But Europe is a very competitive country, and if England can give antibiotic in 1 hour, the Netherlands want to do this in 26 minutes. Is this making patients surviving better? Well, we published this editorial a couple of weeks ago. Actually, we need to be careful in what we're doing, because in the rush of giving antibiotic, actually sometimes we could cause harm to our patient. It should stop us to do that, but probably we should get a little bit more cautious care. This is a publication that came out this year looking at patients that were randomized in 2 groups for receiving antibiotic in the before arriving to hospital. Essentially, this group in the Netherlands trained nurses to give antibiotic in the ambulance before arriving to hospital, and they achieved the goal of having the treatment group receiving antibiotic within 26 minutes, and the control group later, around about 1 hour, just above the hour. The author of this paper concluded that there is no evidence that giving antibiotic before or giving antibiotic in the ambulance makes the patient's outcome better. We will still have patients that are admitted to the intensive care. You still have 4% of septic shock. But the scary and the concerning finding is that the number of positive culture in the patient that are treated early is lower. So sometimes we do not find any bacteria in the patient that receive the antibiotic earlier compared to those that receive it later. There are lots of limitations in this study. First of all, the majority of the patients enrolled were having lung infection, urinary tract infection, which can be easily treated within an hour. Lots of those patients had possibly respiratory viruses, so they receive antibiotic with no reason. There were no patients with meningitis or immunodepressed. The Netherlands is a very small country. I think it's round about the size of Sicily, where I come from. And also 20% of the patients in this study received already antibiotic before entering the ambulance. So there are lots of biases, and actually training nurses to give antibiotic in a rural area or with patients with different conditions might really improve patients' outcome. But nevertheless, we shouldn't be rushing without thinking, I suspect. The other thing which is important to underline is that patients in this study were enrolled using sepsis 2. And there is evidence for recent study, always in the Netherlands, that patients with sepsis 3 are much sicker compared to the one with sepsis 2. So probably giving antibiotic with patients with sepsis 3 criteria might get a little bit better results. We don't know. The other important finding of this study is that training nurses is still important. Recognition of sepsis significantly improved, regardless the treatment, by having a program that engages nurses and the staff, even in the preoperative care. And I think this is an important message to take home. So we talk about timing, but let's go back to individualized care. That's really challenging, we said that. And there's several paradoxes and problems related to that. I think the most important example of difficulties in treating single patients is coming now by the bariatric population. The number of patients that are overweight are increasing all across the world, and they represent a real problem. They are a problem just considering the fact that we're still evaluating bariatric patients looking at the BMI. When I began working with bariatric patients, I felt that probably mortality would have a linear correlation with the BMI. Patient that is super slim is really cute and doesn't die, and as soon as they increase in weight, mortality increases in a linear manner. As you can see from this graphic, this is completely wrong. It's a very interesting shape by which actually patients with low BMI have high mortality. There is an area which is not a BMI of 25, but is higher, 30 to 35, where actually patients do very well, not just with sepsis, but also for a series of other conditions. So that's something we don't know about this population, and still we want to treat them in an individualized manner. One of the big lessons that we have now learned is that it's not about the weight, but it's about the body fat distribution. And there's lots of methods, such as body composition scans, that can tell you where the fat is. And this is important, is relevant, because the BMI doesn't tell you whether the patient is metabolically healthy or unhealthy, because it's the visceral fat that is related to a lot of several of the comorbidities related to obesity. The visceral fat is really an endocrine system and is related to the release of several molecules and is related to a huge amount of comorbidities. This study is an observational study looking at over 1,000 patients and suggesting that obesity is independently associated with reduced mortality at 30 days. If you look closer to this data, patients are very similar, and there's not much difference in the severity of the disease, but if you see the difference in mortality is significant only in the patients that are not mechanically ventilated. If the patients are ventilated, there's no difference among the two. What is it telling us? Do we know what we're doing with our mechanical ventilation? Is that something related probably to the treatment that you give to this patient that is actually taking away the benefit that we see in patients that are not ventilated? Well, just a few slides to go through what we do when we ventilate patients. There are adverse effects related to ventilation, and those effects are mainly due to two elements. One is the increase in the transpulmonary pressure, and the second element is the variability in the pleural pressure, in driving pressure. Both these two elements are related to the specific elastance of the lung and the chest. You can all realize that the chest of a bariatric patient is really different from the chest of a normal patient. We still don't take this into the account when we go and look to our patient. Just a few slides to remind you what is driving pressure. So driving pressure is given by the plateau pressure that you measure with an inspiratory hold minus your PEEP. Is this important? Well, it correlates quite linearly with the adjusted relative risk of death. You can see this is the increase. I don't have a pointer, I'm sorry. Oh, I have a pointer. So you can see it's quite a straight line, I can't use it, between the increase in the driving pressure and the increase in the mortality risk. You might have seen also these other slides related to the mechanical power. Is a concept that seems much more difficult, but actually is not as difficult as it looks. With a pointer, it will be much easier for me to explain to you. Anyway, you can see that in this complicated formula, at the end, you can identify a constant. Then you can see the importance of the respiratory rate. Then the first part of the formula looks at the delta V time the elastance of the chest. So if you have a delta V and you have very stiff chest, the volume that you can generate is much lower. The second part is relatively related to the movement of gas. So to move gas, you need to look at respiratory rate, the inspiratory-expiratory ratio, and the resistance of the airways. And the last part looks at delta V time PEEP. So let's go back for a second. Driving pressure takes away PEEP and doesn't consider respiratory rate at all. And respiratory rate is quite important if you talk about RDS, for instance, because you tend to increase respiratory rate. And then you have this mechanical power that actually multiplies respiratory rate and to the value of PEEP, suggesting that actually PEEP can cause damage. How do we ventilate the patients in the intensive care? How do we ventilate our bariatric patients in the operating theater? There's no enough evidence. Actually, there's no study related to patients like those with community-acquired pneumonia show at the beginning that spend 7 days in the intensive care unit telling you what a decent PEEP is for patients with increased BMI. We have a meta-analysis here suggesting that recruitment maneuvers are useful, but that doesn't show any specific PEEP to use. The ProVelo trial is in the operating theater, it's not in the intensive care, and still shows that if you use high PEEP, you can have a lot of hemodynamic problem. And you don't want those hemodynamic problems in septic patients. We've been part recently as a center to this ProBeast study, which is looking to recruitment maneuver and use of PEEP in bariatric patients. But still, once again, these are in the intensive care unit and not related to septic patients. So essentially, we do apply to our bariatric and non-bariatric patient different strain, different stress, and we don't take those into account. But we have animal evidence that if the strain, meaning the tidal volume time, the total lung capacity, or the stress, which is our transpulmonary pressure, is higher, you can cause damage of the lung itself. This is an animal study, it's quite interesting. You can see down here the hours of mechanical ventilation. Then you can see the strain, which I told you is related to the stress, and up there is the change in the weight of the lung. This means that if you ventilate the lung with a lower strain, the weight does not change regardless several hours of mechanical ventilation. If you ventilate those patients with an increased strain, the weight, meaning increase in the release of mediator, increase of the interstitial fluid, worsening of your oxygenation, is higher in these patients. So what do? Do we know anything about the ventilation of the patients included in this trial that gets no mortality benefit once they're intubated compared to those patients that are not ventilated? If you look to more general results in this same trial, you can see that also the mortality rate, regardless being ventilated or not, has a very familiar pattern. You can see that patients with a low BMI die more compared to the patient in that range of BMI between 30 and 35. If you look to this curve, and you remember the initial curve, you can see this must be something related to the bariatric patient that make them safer round about a specific weight. If you see the results of this trial, there's a suggestion that patients that have higher BMI have higher level of CRP and more frequently are diagnosed as having SIRS criteria. It seems like those patients have a pro-inflammatory states that might actually make them protected in a way against bacterial infection. This same finding has been recorded in several trials around the world for hospital-acquired pneumonia, for community-acquired pneumonia, for RDS, showing better survival if you have a BMI between 30 and 35. If you see patients undergoing cardiac surgery, you can see that even them have higher level of C-reactive and they have a pro-inflammatory state. So we have an answer for this problem. Patients that are fat, if there are less problem with the ventilation because we don't have a very high transpulmonary pressure, and they have a better response to bacteria because they have a pro-inflammatory state. But what if we talk about influenza? You might remember a couple of years ago, patients, the pandemic of influenza showing higher mortality in bariatric patients. So what's going on? Is the immunity of these patients not working for viral infection? We conduct this study in our center where actually we were including patients undergoing elective bariatric surgery. We collected bowel, tracheal aspirate, plasma, and urine. And what we did, we incubate the plasma of these patients with influenza virus. What we found out is that the response to the influenza virus at the beginning is really normal. The virus gets inside the cell, activates the pathogen-associated molecular pattern in a normal way, leads to the release of toll-like receptor, that gets to the delivery of cytokines. And in fact, the plasma of these patients has high level of cytokines. But what else is measured in this patient is a high level of leptin. We did several studies. What we realized is that probably leptin is causing the lack of antiviral activation. Once the interferon goes into the macrophage, there's no translocation of the signal from the cells into the nuclei, and there's no release or activation of this antiviral effect. So what to do? Well, sepsis is becoming very common, but bariatric patients are also very frequent into our unit. There's a lack of homogeneity in the elective surgery about what antibiotic to use. There's a huge lack of knowledge related to the intensive care patients. We started now measuring the level of antibiotic in our elective patients with a study that's called the PAVENT study. We follow only 3 antibiotics, which are the 3 most usually in our practice, coamoxiclav, clindamycin, and gentamicin. And we hope by next year, if you want to invite me again, to have some results regarding pharmacokinetic and pharmacodynamic of this agent. I think we are still far away from individualized care, even in a broad sense, looking at big group of patients such as bariatric patients. So in conclusion, I think timing is crucial for treating septic patients. There's lots of controversies there. Individualized care is something we've been dealing for the last 20 years. I'm sure we have new technology, I'm sure we have new understanding, but it's nothing new in the concept. And I think probably the future will be looking at long-term outcome on whatever we do for our patients. With this, thank you very much for your attention, and we take questions at the end.